signed in. Professor Reddy and Dr. Banerjee, are they connected?
I can't see them online as yet.
Conference room, RS?
Sir, Amitabh sir is joining soon. He's facing some problems, sir, actually.
It's a bandwidth problem here, so I will, just to be on the safe side, I will keep the standby connection ready. I will
Sorry,
have
if
to
you are
speak
facing
slowly.
some brand, okay, you just switch off your.
Your end.
No, your voice is cracking, sir.
Yeah, I will switch off the video.
Yes. You just switch off your video.
That is low bandwidth. Okay. Is it better now?
Yeah, I think your voice seems fine now.
Yeah, I
Yes,
think
it's
there's a
better.
problem issue with the bandwidth.
What password did you try? Good evening, Professor Reddy. This is Sunit Tandon. I'm the director of the India Habitat Center. And yeah, good to meet you virtually. We are waiting for our distinguished lecturer to join us.
Good afternoon.
Good afternoon, sir.
Can you see it? I mean,
Yeah, yes, sir. So Dr. Amitabh Banerjee is having some problems connecting. So he is trying to join by mobile now. So he'll be joining in 1 minute or 2 minutes.
yeah.
Joining in 1 minute or 2.
Okay. Okay. I'm going off the video because of the low bandwidth. So I assume you can hear me clearly.
Yes, sir.
Dr. Amitabh. Hello.
Hello. Is that Dr. Amitabh? Are you there?
Resend link.
I hear Dr. Amitabh Banerjee.
Hello. Hello.
Yes, hello, Dr. Banerjee, welcome. Can you hear us, Dr. Banerjee?
Good evening, all. As there are some technical issues with Dr. Balakrishna's connection, we regret that he is not able to join right now. He will join a little later. Good evening, Professor Srinath Reddy. Good evening, Mr. Sunit Tandon. Good evening to all the other speakers and participants. It's my pleasure to welcome you to this STIP forum lecture, which we hold every month, and RIS in association with the partner institutions. It is a great privilege and honor to have Professor K. Srinath Reddy, the Doyen of Public Health in India. And it's our honor to have Dr. Amitav Banerjee, who is with UCL London. He's a data scientist, he's a cardiologist, he's an expert in public health, he's an expert in epidemiology, and we have worked with him in a project which involved digital health, and his contribution has been immense in the sense that he's a multifaceted person who links data with public health, with policy, with epidemiology, and besides being an active in some of the civil society initiatives in health. So it's a really great pleasure to have two stalwarts in this lecture series today. I request Mr. Sunit Tandon to speak a few words. After that, Professor Srinath Reddy will give his presidential remarks. Thank you, sir.
Thank you, Mr. Srinivas. It's a great pleasure for me to join in this virtual lecture in the series of the STIP forum, which was started in 2017 and has been a wonderful continuous series, which has had a small series of hiccups during the lockdowns. But I am so happy to report that RIS, particularly out of all our institutions who collaborate in arranging this series of lectures, has taken the initiative to make these lectures happen as regularly as possible, even during the pandemic, and take them onto the virtual platform. So I'm absolutely delighted to join everybody on this particular lecture, which is a very important topic, even as we are grappling with the urgent need for hospitals, ICUs, oxygen, and life-saving drugs present in the short term. We are looking forward in this topic to COVID-19, the urgent need beyond the ICU, the hospital at the short term, by a very distinguished guest, Dr. Amitav Banerjee from University College London. And I'm delighted that Professor K. Srinath Reddy, one of our foremost public health specialists in the country, is chairing this particular lecture. So it's going to be a very, very useful lecture for all of us. And I'd like to welcome all of you and to request that we carry on with the lecture without any further ado. Thank you very much indeed.
We request Professor Srinath Reddy to give his remarks, welcome President's remarks, and then kindly narrate the STP lectures. Thank you, sir.
Thank you very much. I do not know whether Professor Banerjee, Dr. Banerjee has already joined or not. Has he managed to overcome the technical difficulties?
He's joining by his mobile. There is some technical issue, but he's joining through his mobile phone. He'll be joining.
The reason is that I did not want to cut into his time. So I want to make sure that he has adequate time despite the late start.
We can extend the time, no issue at all. We are willing to hear you and so
right.
extend the time. Absolutely.
Right. Well, thank you very much for asking me to chair this. I've known Dr. Amitav Banerjee for a number of years, and I've had an opportunity to work with him in some committees and also discuss several projects with him, and I have immense respect for him and for his multifaceted contributions to cardiology and public health. I do not know exactly what aspects he's going to touch in his lecture. The title, of course, is very interesting, but opens up several opportunities for wide-ranging discussion. When we talk about COVID beyond the ICU and the hospital and the short term, it actually brings in several things. It could bring in immediately in the context of the post-hospitalization phase, the long COVID challenges, which one needs to document in terms of what is happening into the people who have recovered or only partially recovered from COVID. But it also brings in the whole area of vaccination for protection of the people. But much more importantly, in my view, it brings in the whole area of health systems. Quite often, the attention in COVID is focused on the hospital and the intensive care. And the ventilator was the prime dominant symbol, both in the media and in our imagination in the first wave, before it was shown very clearly that it was needed very little and benefited very few. But we recognize, of course, that we do require intensive care units, we do require oxygen, we need proven drugs to save valuable lives. But the whole area of containing the transmission, of preventing the infection in the first place, of identifying people both on the basis of tests and on the basis of symptoms, of identifying the travel history and the contact history, exposure history, and then deciding what is the probability of a person having COVID, even if the diagnostic test initially turns out to be negative. How do we advise home isolation? When do we transfer to the hospitals or intermediate care units? How do we actually ensure that the contacts are traced appropriately? All of these are important elements. And of course, the whole area of vaccination brings an additional element. The reason I'm mentioning these is that these are all part of the primary healthcare mandate. Unfortunately, primary healthcare is one of the most neglected areas in health systems, especially urban primary healthcare. And that is where we have fallen short in our response to COVID in terms of delayed recognition of cases, inadequate contact tracing, not able to build vaccine confidence. So there are so many areas where we believe we must indeed strengthen our primary healthcare systems, our secondary care hospitals with oxygen supply being assured, and of course, timely emergency transport between primary to secondary or to tertiary care. All of these are important elements of health system strengthening that we must really look at. because weaknesses in the health system are something that will extract a huge price, even if we have some advanced care hospitals which are of high repute. And if we do not invest adequately in building a health system which has both efficiency and equity as key dimensions uh, at all levels of healthcare, in a comprehensive primary care which is connected and has adequate ability to send patients and receive patients back from advanced care, and also making sure that we have adequate follow-up of people who are initially relieved of their symptoms, but later on need to be provided continued care. So the continuity of care becomes very important as well. So all of these are elements that need to be strengthened in the health system. But most of these also require data. And particularly when we have decisions to be made at the field level, we need data-driven, decentralized decision-making. We need data for immediate analysis and response at the ground level. Then we need at the district level, district management level, we need additional sets of data or extended sets of data for supportive supervision and monitoring. Then at the state capital level, you require, of course, even more amplified optimal sets of data for course corrections, resource allocation, and making sure that the program is actually being adequately steered. So these are all important data gaps that we are having. And even in terms of the variants that are emerging, unless we do genomic analysis and match it against the vaccines that we have, we will not be sure whether the vaccines we have are protecting against the variants that have emerged, and or whether they're inadequate and whether we need to do something more. There are many areas, therefore, that our response has to be driven by data. Has he joined?
Yes, I'm here now. Can you hear me?
Dr. Barry, okay, absolutely wonderful to hear you. I was filling in the gaps for you.
No, sincere apologies from my side.
Well, we are all ears now. So I will not make any further comments. I was just filling in the gap till you joined. I was actually going to reserve my comments till after your lecture.
Okay, great. Now, Amit, would you mind showing my slides since I'm on the phone? Would that be possible?
Yeah, sure.
Yeah. You could show my slides. See. Would that come up under the RAS conference room? Where would I be able to see that?
Yeah, just a minute, sir. Just a minute.
It's not a WebEx meeting unless I have a hitch. So my name is Amitav Banerjee. I am Associate Professor in Clinical Data Science and a cardiologist at University College London and Barts Health NHS Trust. And I also have an adjunct position at Amrita Institute of Medical Sciences in Kochi, Kerala. As my slides are coming, I'll just mention that as well as my research interests in COVID. Thank you so much, Amit. So if you could go to the next slide, please. So I'm going to talk about the need beyond intensive care, the hospital, and the short term. Can you hear me clearly? Just my conflicts of interest. I have research grants unrelated to coronavirus from AstraZeneca, from the National Institute for Health Research and UK Research and Innovation. I'm a trustee of the South Asian Health Foundation. I'm 30% of my time clinical as a cardiologist, and 70% of the time I'm academic. And I've been working clinically throughout the pandemic, whether in intensive care or in the general wards. And I have family, friends, and colleagues in India. I visit very regularly. So my biggest conflict of interest is my Indian blood. Next slide, please. We, as well as the tragedy that is hitting us across the world in terms of coronavirus, we are facing a death by dashboard, where all of us have become so used to monitoring these figures. And this is actually the latest figures from the World Health Organization. You can see 3.5 million deaths there have been, and so many millions and millions of cases. If you advance, please. We've been seeing in the UK about since March for the hospital numbers. You can see here in our second peak in December, January, we were actually much worse than the first peak, where we thought in between that we had cracked it, that we had got over the pandemic. Next slide, please. And this is done in various ways, and you're used to seeing the same in India now as well, by region, by state, by hospital level, and this kind of sit rep or situation report was very common for us clinicians and in public health at a policy level. Next slide, please. Of course, this field hospital capacity that is required has got parallels with the pandemic of 1918, where capacity was so short. And in the UK, we had a period in March 2020 where we started building field hospitals in the form of Nightingale hospitals, with an extra 4,000 beds in the London Nightingale Hospital for intensive care for coronavirus patients. We very quickly found out that actually the rate limiting step was staff rather than beds, because each bed requires a ventilator and somebody manning that ventilator and medical and nursing input. And also we did a study here that I've shown in +1, where we did a simulation to show that clinical research would grind to a halt. Just when we needed clinical trials and clinical research, we wouldn't have people to be able to do it in that setting. And so, next slide, please. We modeled that if we allowed the infection rate to go up, then we would have a peak unless the infection was suppressed. That's what the orange line is there. Whereas we suppressed it, there would be low levels of infection and workforce could continue as near normal. Next slide, please. And this is the situation that's facing India now, which we faced throughout 2020, where because we had high strain on the health systems, all of our health resources were devoted to coronavirus. And so in this case, a shortage of clinical academic staff or nurses, ICU doctors and so on, the doctors and nurses themselves were going off sick with coronavirus. So the way to avoid this is infection suppression. Next slide, please. And the reason we're focused on intensive care is because we haven't got to grips with the early data of what are the risk factors actually for coronavirus mortality. And we knew this since Wuhan, since December 2019, January 2020. We knew that age and underlying risk factors, namely heart disease, chronic lung disease, chronic kidney disease, diabetes, these were the most powerful risk factors. In this case, this is from the Open Safely study using UK primary health care data, which shows this, but this has been emulated in every country. Next slide, please. We were interested in excess mortality from coronavirus from a clinical point of view because the patients not in intensive care, the people in the community, were very concerned what their risk, what their mortality risk was. A patient with heart failure asked me on 16th of March, 17th of March, why he was being asked to shield, to stay at home. What was his increased risk above his heart failure that meant that coronavirus was more of a threat to him? So we set out in our team with my colleagues here at the bottom of the slide to answer this question using UK primary care data. And all we knew at that stage was those risk factors of age and the different underlying conditions. And we modeled using UK primary healthcare data to show by the 22nd of March that if we did not suppress the infection rate, we would be looking at upwards of 70,000 deaths in the next year. We immediately sent our results to the Chief Medical Officer of the UK and posted our results to preprint server. And as a result of our results, the country went into lockdown on 23rd of March last year in the UK. Next slide, please. It's important to note when we produced our model, there were only 79 excess deaths, and now we have nearly 130,000 deaths in the UK. These results were published in the Lancet last year. Next slide, please. The basis of the model is quite simple. It is that the risk of dying from coronavirus is related exquisitely to your baseline risk of mortality, which is related to age, gender, and underlying conditions. In this slide, you can see the baseline risk at 1 year related to these different factors. So at the top right in the men, you can see upwards of 20% mortality per year in certain individuals. So there's an individualization of that risk. Next slide, please. During the pandemic, that baseline risk interacts with the infection rate, which is at the top of the slide, where on the left-hand side, you have full suppression of the infection rate. And on the right, you have a free infection rate, if you will, do nothing. And that's where the death rate is highest. On the right-hand side, down the vertical axis, you can see the relative impact of the pandemic. That's the third factor. So baseline risk, infection rate, and then how much does coronavirus increase the mortality rate above the baseline? And so we modeled up to threefold increase. That led to the estimate of over 70,000 that you can see there. Next slide. Next slide. Sorry, keep it on, please. The next slide shows that this model has been used in various ways. We used it to model excess mortality in cancer patients in the UK, and we used it to model across different countries using the global burden of disease data, including in India. We've used it in cardiovascular disease patients from China to Italy to the United States. And most recently, we've used it to model the impact of vaccination in patients with these underlying conditions. We've also, next slide, please, looked at the impact of the lockdown and coronavirus itself in people who are overweight and obese, where there's a balance to be had between the inactivity from lockdown versus the excess mortality. We've now had a year of pandemic or more in the UK, where we can now look at national records and see whether this model has been borne out. And what we know is that there have been 130,000 deaths where we were predicting in the order of 70,000 if there was 10% infection rate and if the relative risk of the pandemic was threefold more than baseline mortality. So we have looked, next slide please, at the same conditions that we had outlined before in our Lancet paper that are the high risk conditions for coronavirus. And we've looked in UK national data, 56 million records. This methodology has been published in the British Medical Journal last month. And we can, with quite high granularity, look at patients who developed heart disease before or after their coronavirus infection, for example. And so we can look at the different impacts of these underlying conditions. Next slide, please. The take-home message is, on the left-hand side from our Lancet paper, we predicted certain mortality per 1 year from these underlying conditions. And that's on the left, on the right-hand side of this slide, I apologize, listed as pre-pandemic. And in the pandemic, you can see that there has been up to 5-fold increased mortality in these people who are high risk. We're not the only people who are interested in excess mortality. From the research side, this is of great importance from a policy and a public health perspective. Next slide. The global burden of disease study in particular has listed a whole host of factors that it is now monitoring. Next slide, please. Including not just the excess death due to coronavirus, but also the indirect death due to delayed care for other conditions, increased mortality from mental health disorders, increased mortality, reduced mortality due to reductions in road traffic accidents and other injuries. There's been a reduction in influenza and reduced transmission of other viruses, and so reduced mortality due to those. And there's also reduced mortality because people who would have died from their cardiovascular disease have died from COVID in the last year or so. So these are all factors that we're taking into account when we're looking at national and international level. Next slide, please. We have looked in cancer and seen that there's been a drop in activity, whether in terms of outpatient referral, whether in terms of surgeries. Next slide, please. We've looked in cardiovascular disease that the same has happened, a reduction in activity for cardiovascular disease, leading to an increased risk in these patients. Next slide, please. And most recently, we've shown that there's been a huge drop in endoscopy, both upper related to cancer services. So if we don't reduce infection rate, reduce the number of cases and deaths, the whole other sector of healthcare, non-COVID healthcare, will grind to a halt, and those backlogs will persist. and cause more mortality far beyond the ICU in the hospital. Next slide, please. This has been termed a syndemic by Richard Horton, the Lancet editor, where it's not just an infectious disease, but undertreated and under-recognized non-communicable diseases, and the so-called social determinants of health, which Professor Reddy has been a champion of in terms of research and clinical practice for many years. This syndemic term captures the fact that this is not just an infectious disease. We have to think of this in terms of the baseline risk, whether it's cardiovascular disease, whether it's diabetes, whether it's chronic lung disease. And therefore, the solution is not just treating an infectious disease. Next slide, please. Beyond the short term, the next threat to all of our health systems is long COVID. We showed really in the first large-scale analysis in the British Medical Journal that using national health records in the UK, even in people who were discharged from hospital following COVID admission, there is high risk of readmission, and 1 in 10 of them will die in the next 4 months without proper care. And there's increased rates of cardiovascular disease, diabetes, chronic kidney disease, and lung disease. Next slide, please. We know that people who have underlying diseases, in this case, fatty liver disease, have increased risk of hospitalization and serious effects from coronavirus. On the right-hand side, we also have shown that people who have coronavirus infection, even those who are non-hospitalized, show signs on imaging of some abnormalities, such as in the liver, such as in the heart, such as in the kidneys, 4 or 5 months after their coronavirus infection. Next slide, please. And this is even compared with healthy controls. I'm on the left-hand side showing that these patients with long COVID have a plethora of symptoms that are coexisting, which we haven't got to the bottom of, and we need to gather more data and do more research to find out the pathophysiology and therefore what the treatment and management of these patients will be. Next slide, please. We have been so caught up in our health systems, and that includes the UK and now India, in the acute stage of the pandemic and dealing with the intensive care and the hospital side, that on the bottom you'll see the green, our approach and our strategy for long COVID, the chronic complications of COVID, has been sparse at best, whether in terms of funding, in terms of healthcare resource, and so on. And yet, in the middle, in the red line, we have seen a spike in the referrals and the presentations of long COVID in the UK. In the UK, a country of 60 million, we already know that the prevalence of long COVID is 1.1 million in the last national survey last month. Next slide, please. And the good news is, in all of this, that we have known since the beginning that there is no situation where infection suppression is bad for you. The best way to avoid COVID complications, intensive care, and long COVID is to stay at the left of this chart, is to stay away from infection. If you do get infected, then we need to make sure you're assessed and monitored early on, and we need to have integrated care across specialties. Next slide, please. India was in a very good place in the summer of last year, when, with colleagues from Amrita Institute, we wrote this piece in the BMJ Global Health. Next slide, please. And it was coordinating its response in terms of both community level, local government, and central government to keep the infection rate down, even in densely populated areas. Next slide, please. Recently, I published this opinion in the BMJ Next slide, where really the problem is that we have all fallen for this in different countries, including my country in the UK, where we've thought we've got through it. And we cannot take it lightly. We cannot be complacent, any of us. And we definitely cannot ICU our way out of the pandemic. Next slide, please. The way out is vaccination and keeping the infection rate down, but also we need to think across our usual disease silos and specialties. The old tale of the Indian elephant, where we're all blindfolded and looking at one particular part, and the cardiologist, dermatologist, pulmonologist, intensive care doctor, we can't do it like that because we haven't got enough resource, but also this is a multi-system disease, not just an infectious disease. Next slide. And that requires what we call a learning health system approach to both COVID and long COVID, where we're, as my colleague Melissa Heitman, who runs the first long COVID clinic in the UK, says, we're building the plane while we're flying it. We are finding out the data about what long COVID is and how to treat it at the same time as developing guidelines. Next slide, please. So to conclude, Professor Reddy and colleagues, I would say that we have to think beyond the intensive care unit. We have to think beyond the hospital, and we have to think beyond short term. Most people who have COVID and die from COVID are not in the intensive care unit. Most people who have coronavirus do not reach hospital. And more people are going to have chronic complications than the people that you see having acute complications. COVID-19 is doing a very good job of exposing existing inequalities in our health systems and in our societies, and we must be aware of that. Complacency is the other C word, other than coronavirus, that we must be aware of. That is what has been a problem in our countries, and we need to have adequate, simple health infrastructure to manage in terms of social distancing, keeping the infection rate down, and vaccination. That's my final slide. I'm happy to take questions. Thank you.
Thank you, Dr. Banerjee. Thank you very much. You have really provided a very comprehensive overview with very clear messages that the tiny RNA virus has become a great teacher for all of us, telling us that these are complex systems which cannot do with linear thinking and siloed solutions. So bringing in that picture of multi-component responses, particularly in terms of containment of transmission, but also ensuring that the care, whether in hospital or outside, is a very integrated care. I think this is a very clear-cut message that we all need to register. Now I open up for any questions. I believe there would be people from RIS who would be assisting in identifying the people who are posing the questions on the chat box and calling them out to ask, or posing the questions as framed in the chat box. Are there any questions that are being directed at Dr. Banerjee? I'm afraid I can't see the questions on my instrument because I'm operating out of an iPad and I can't see the chat box here. Who is curating the questions, please?
Dr. Amit will be doing it, sir. Dr. Amit Kumar will be, correcting the questions and then he will be reading them out.
Okay.
So I see some people raising hand, but as attendee, I have written to them to write their question in the chat box. So because they cannot use their audio and video as attendee.
But then somebody should curate the questions and share them with Dr. Banerjee.
Professor Reddy, do you can I ask you, in your view, the what we've called the high risk population, the older population, the people with underlying conditions, are they in the Indian context? Obviously, I know that vaccination has been prioritized in them. Do you think the message has gone out clearly enough to make sure that they are distancing and keeping the infection rate down there? Because in the UK and elsewhere, we've seen that 95% of the mortality has happened in that group.
Yes, here too, basically we are seeing that the higher mortality is determined by age and by the presence of comorbidities, particularly associated risk factors like diabetes and cardiovascular disease, hypertension in particular, and chronic respiratory disease. And all the classical risk factors that you have mentioned are very prevalent in India, particularly in urban areas, but also in rural areas to some extent. But one of the things that is of great interest, of course, in the Indian context is the high prevalence of both diabetes and pre-diabetes. And the fact that adiposity, which is usually seen as conventionally defined as obesity, is actually manifest much more in terms of visceral adiposity or abdominal adiposity in India. And even the proportion of fat, body fat, to the lean muscle mass is higher in India than elsewhere in the world. So it's the total adiposity of the body and the distribution in terms of abdominal fat, the visceral adiposity, which predisposes to diabetes and cardiovascular disease, but is also associated both through them and independent of them with higher levels of inflammation. In fact, all of these are unified by inflammation as the common theme. And that itself can actually damage the blood vessels and also predispose to much greater thrombotic events in the case of a COVID infection. So I believe it's absolutely important for us to ensure that people who are at risk, either because of an older age or because of associated comorbidities, must be identified and protected. The problem is that many of the people with diabetes and pre-diabetes are not already identified by the health system, especially in smaller towns and villages. And that is where those failures of primary health care must be remedied so that we actually do identify them and protect them with prioritized vaccination.
I think that this is, in many ways showing something that you've spoken about for many years about the social determinants, but also the non-communicable disease risk factors underlying much more than cardiovascular disease outcomes. It's influencing the outcome from this pandemic in terms of the baseline risk. So do you think that means that we have to keep monitoring and managing that non-communicable disease risk, even though we're obviously diverted by the threat of coronavirus at the moment? Because that's what we're finding challenging in our setting.
Absolutely. I think you brought out that point very well. Firstly, that pre-existing cardiovascular disease and diabetes and obesity predispose to higher risk with a COVID infection. But even the restrictions that we are imposing as a result of our public health response to COVID are also accentuating some of these, both by the nature of sedentariness, the inability to get adequate attention and testing done for non-COVID health conditions, and even the type of foods that we are forced to consume when the markets are not providing us fresh vegetables and fruit, but we are dependent more on ultra-processed foods purchased. So there are so many issues that do come in of how this becomes a mutually deleterious cycle of cardiovascular risk predisposing to COVID and the COVID response enhancing the cardiovascular disease risk as well. But we do need to break that vicious cycle by ensuring that our health system is far more alert and agile in identifying these risk factors and health conditions. Just to give you an example, why is it that when people are actually going for their vaccination and they have to wait for 15 to 30 minutes over there before the shot or after the shot, quite often people have to wait a fair amount of time. People who are, they can have their blood pressure and blood sugar checked. The simple things to be checked over there so that we can do opportunistic screening to fill in some of the gaps that we have in detection of some of these conditions, especially in villages and smaller towns. Why can't we organize our health services to detect much better? So all of these are issues that we ought to be really thinking about in our health system to fill in some of the gaps in terms of detection of some of these adverse risk factors and comorbidities.
I can see, thank you, Srinath. I can see a couple of questions have come. One is, how are we preparing for the third wave, and will we need a booster dose of the vaccine for that? I think I can speak for the UK that this is a concern. There are plans afoot to have booster doses, probably in the autumn and winter. But whether these will cover different variants as they come along is obviously an issue. And I believe this will be the same concern regardless of country. I think the preparation for the third wave would be that we have now, at least on 3 occasions in the UK, been hit by the thinking that we have cracked it and opened up the country totally without monitoring. And actually, early in the pandemic, in January of last year, it was announced by WHO that the way to do this was testing and tracing, keeping infection rate down, and managing our borders. So nothing has changed, whether it's the third wave or the second wave, in my view. I don't know if you want to add anything to that, Professor Reddy.
No, I entirely agreed. I mean, we are living in times of uncertainty because we do not know which variants are emerging and what the efficacy of the currently available vaccines will be against the future variants. Therefore, we have to definitely keep updating our research and our data, particularly in real world data, and then take those decisions. But one of the things that we must recognize is that whatever may be the variants, there are only 3 gateways in which they can enter our body, which is the nose, the mouth, and the eyes. And if we can actually keep ourselves protected with adequate masking, and we do not know how long we need to do that, but certainly in terms of avoiding super spreader events, one of the biggest damages that we can inflict upon ourselves is to have crowded situations and give the virus an easy opportunity to infect many people. So it's not just the behavior of the virus that matters, it is our behavior also that matters substantially. And that is one factor we should be able to modify and in turn influence the behavior of the virus.
Great. I've got another question here that says, any specific treatment strategies for long COVID? Actually, we haven't got a specific proven treatment for long COVID other than not getting infected with COVID in the first place. But there are many candidate therapies that are being tested now, including antihistamines, antiplatelet agents, anti-inflammatories. But as yet, we haven't got a therapy. The mainstay in the UK is actually rehabilitation, but we now have data showing that even in people without underlying conditions, unlike the hospital acute COVID phase, the long COVID can be in people who are younger and underlying conditions, and that can cause impairment of their daily function for many weeks and months. So it's another reason to try and reduce the infection rate and the risk of being infected. There's another question here: is age as mortality risk factor changing with emerging mutants like the UK or Indian variant? More risk in the younger? I think we've seen slightly more risk of infection. We haven't yet seen increased risk of severity in younger people with the new variants, and long may that continue. That would be a worry and would be a huge added strain on the health system were that to happen, but we have to guard against that. The last question I can see here is: there is a fear that the third wave will affect children badly. How real is this fear? So we're monitoring this very closely. I'm afraid I don't have the answers there. We are seeing increased reports in later waves of the pandemic of non-specific symptoms and sometimes more specific symptoms in children. But I would say that we can only analyze if we record and report the data, and that hasn't been in the first wave gathered as well as we'd like in children. I don't know if Professor Reddy wants to add.
If I may come in here, basically, I think this is a speculation by deduction that most of the adults would have been either infected or vaccinated by the time the third wave comes in. And therefore, the virus would seek new susceptibles, and therefore, children and adolescents would be affected in larger numbers. Certainly in a freely mobile population, they would be the ones definitely affected, partly because of higher mobility and partly because they're among the susceptibles still left to be infected. But there is no evidence at the moment that the manifestations are going to be clinically more severe or the mortality is going to be higher. So right now, I think we need not push the panic button. I think the most important thing is for adults not to actually allow the transmission of the virus through their own behavior. And if they take adequate care, they will protect the children from getting infected. Therefore, the adults need to behave more responsibly rather than merely speculating whether children are going to get affected more.
Yeah, no, I agree with that totally. And in terms of vaccination in India at the moment, which age strata is being prioritized now? Or what proportion of those high-risk people have been vaccinated at the moment?
Well, at the moment, we have only about little over 13% vaccinated and about more than 3% having 2 vaccine doses received. But most of them have been people above the age of 45 or with comorbidities.
Yeah,
because those are the criteria initially set, and most of the vaccination has been done through the government centers.
Thank you.
Yeah, Dr. Banerjee, there are a couple of more questions which has come. There is one question is, do you see third wave coming to India soon enough, or is there is still a time to prepare more robustly to deal with it? And second question is long COVID self-limited? Or what is the average duration of the symptoms that will come with this kind of long COVID that you mentioned? And the third one is black fungus and white fungus so rampant in India right now are signs of long COVID? So these 3 questions have also.
Thank you. On the third wave question, I think we know now from repeatedly seeing the cycle in other countries that we need to test, trace, and suppress infection rate, monitor border controls. Rather than speculating if there will be a third wave, we should do all in our power in our respective countries to reduce the impact of that. And whether that's reducing the infection rate by social measures or vaccination, we now must do that. across countries. We've seen repeatedly none of us are safe unless we're all safe. So that's the first question. The second question was about, sorry, remind me. It was about.
Is the long COVID self-limited? And
Yes.
what are the
Yeah, thank you. So we know that about 10% of people who get infected have symptoms that persist up to 12 weeks or beyond. So think of about 10% of people having long COVID. How their symptoms progress after that is difficult to see because we need adequate follow-up. But I can tell you that in the long COVID clinic at University College London, they have been seeing people with several months, more than 6 months of symptoms, ranging from myalgia and headache and dizziness to what's being known as brain fog, confusion and inability to conduct their daily activities. So this is in no shape or form a benign infection, and that's why keeping transmission down must be the aim everywhere. And sorry, the final question related to the so-called black fungus. Now that's something we have not seen in the UK and Europe so much, and is obviously being seen more in India. I'm not sure whether that. I don't think that's necessarily a feature of long COVID per se, rather than to do with the effects on the immune system of the treatments and of the virus per se, and it seems to be more acute. Long COVID is at the moment defined by the longer term persistent symptoms. We don't know the underlying pathology or physiology, and there are likely to be different subtypes of it. So people who've been hospitalized have different long COVID symptoms and progression versus people who've been not hospitalized.
Thank you, sir.
Any other questions? There's a question about, are we heading towards herd immunity? Well, the best way to head to herd immunity is to get vaccinated. Then we'll have the kind of herd immunity that I like. Until then, I would not say that we have immunity of the herd.
May I come in here to supplement what you have said? Well, this whole idea of herd immunity is a bit of an illusion at the moment in terms of people getting naturally infected and getting herd immunity. And fortunately, while this particular notion prevailed a lot last year and even early this year, this has now been dispelled substantially. And we did pay a price for that because our lack of preparation for the second wave is partly because many people in India believe that we have acquired herd immunity. Firstly, the idea of herd immunity being an individual protection is incorrect. It's a population attribute. If a large proportion in a group, which is a fairly stable, static group, get infected, the remaining are immune by vaccination. The people who are not immune, either by infection or by vaccination, are protected because the others are blocking the virus from transmission, and these people are in a protective cordon. The moment they step out of that cordon and go to another place where the transmission is active, they're no longer protected. Therefore, it's not an individual attribute. And in a highly mobile society in the world, when one person moves from one part of the city to another part of the city where the transmission rates are different or the immunity rates are different, or to another city in the same country or another country, that protection doesn't exist. So as Dr. Banerjee said, the best way is to acquire the protection by vaccination, which gives you stronger and longer immunity than a single encounter with a virus, an infection, which may have a very variable viral load and therefore may have a very variable duration and strength of the immunity that it confers. It could be just 3 months, it could be 6 months. And then afterwards, you're no longer immune. So to lay our bets on herd immunity as our savior would be very foolhardy indeed. Therefore, vaccination would be the best way forward.
Thank you. Thank you. I wondered, as vaccination is happening, now at pace in India, what can be done to do it quicker? In the UK, we kind of opened up round the clock vaccination. Now we're at the stage where we're opening it to younger groups gradually as well. But I think now there's global issues of supply chains and so on. What do you think, Professor Reddy, are the kind of solutions that we can collectively come up with for this?
Unfortunately, for several reasons, our vaccine availability has become low at the moment. And even the dosing intervals have been extended to some extent for the Covishield vaccine, partly based on the UK experience, where it has been said that up to 3 months of interval is fine. But in general, there is a bit of a constraint in terms of vaccine availability. Particularly since India has announced a universal adult immunization of everybody above 18 years. I think we now still have to retain our priority for the older age group and those with comorbidities, and then try and step up the production of those which have already been licensed in India, to scale up their production as quickly as possible with whatever government support is required, and then hope that some of the other vaccines that are under trials in India or international vaccines that are being given to India for licensed manufacture, that they will all make the grade in terms of meeting regulatory approval and coming into the supply chain by July or so. But till that time, we'll have to prioritize those who are elderly and with comorbidities for the very right reasons that you have stated, that people at risk are those who are having these kind of vulnerabilities.
There have been parallels that have been drawn between the situation for antiretrovirals a decade or two ago and now the COVID vaccination. And in the former situation, India really became the world's pharmacy. Without India's contribution, I think it's absolutely right to say that we wouldn't have the global reach of antiretrovirals that were there. What can we learn going forward? I hope and pray that India gets through the current phase, but we need a global solution to availability, accessibility, because if you look now, that most of the doses that have been given have been in the high income countries. There's barely anybody who's double vaccinated in any low, middle or low income countries, and they're not expecting to be for the next year or so. That's not acceptable or sustainable. How can we do differently?
India and South Africa both have conjointly tabled before the World Trade Organization a proposal that for 3 years, because of the COVID pandemic, the intellectual property right related constraints should be suspended for vaccines, diagnostics, and any other, and for medicines. And therefore, these 3 technologies should be freed from the restrictions of IPR, and any country which is capable of producing it should be allowed to produce and supply itself as well as the rest of the world. Now, that is a proposal that has been opposed by several countries from the high-income group, but recently President Biden has said that United States will change its stance and possibly provide limited support. The problem in India is that we could issue compulsory licenses, which is permitted under the Doha Declaration. for any public health emergency. And there is a demand that compulsory licenses should be issued. But one of the other problems that we have had is that while we do have a very high manufacturing capacity for completed products, some of the raw materials still have to be imported from elsewhere. And in this case, for medicines, it has been mostly from China, the APIs, the active pharmaceutical ingredients, and for vaccines, it has been mostly from the United States. And some of the restrictions placed there because of the Defense Procurement Act in the United States, as well as the other reasons from China, we have not been able to get the raw materials in full flow. Now, we are trying to see how that can also be overcome. Apart from stepping up domestic production, there is some indication that the raw material flow from US would possibly resume.
Thank you. Amit, are there any more
Yeah,
questions?
may I request Ambassador Dr. Balakrishnan to deliver concluding remarks?
Thank you.
Are you there, sir? Hello, Dr. Balakrishnan, are you there? I think there is some problem in connectivity at his end. So let me extend this warm vote of thanks to our chair and speaker on the behalf of my organization. Thank you so much, Professor Reddy, for chairing this session and guiding us through this lecture with your wonderful, remarkable comments on this COVID situation and the preparedness at the level of our country. And thank you, Dr. Amitabh Banerjee, for actually very enlightening lecture, bringing in the role of data science to help take a policy decision which is evidence-based, and also to prepare for the long-term tackling of this whole COVID situation. So what you brought is that this is not the end, or we should not see it as nearing towards end. It can go a little more further, and we should be prepared to deal with it. And it is not just beyond just hospitals and ventilators what we are thinking of. It's all integrated whole system which you need to revamp in order to deal any such situations in the future. So thank you so much, sir, for your fascinating lecture. And this is the 35th STIP lecture since 2017, and we are always honored with such a wonderful speakers for last 4 years. So thank you so much, Chair, and thank you so much, speakers, and thank you so much all the participants for posing questions. Very, very relevant questions and very wonderful replies by the speakers. Thank you so much. Have a nice day.
I too would like to thank Dr. Banerjee for a very lucid lecture. In a very brief time, he covered the full expanse of important elements of COVID response. And I think that's been remarkable from the point of view of giving us direction, even as we are grappling with the problem in India. Thank you, Amitabh.
Thank you.
Thank you, sir.
Thank you for the invitation.
So
See you.
have a nice
Bye-bye.
evening, sir. Thank you. Bye-bye.